Welcome, everyone. This is Lynn Kintz with the Hemophilia Council of California. The Hemophilia Council of California's mission is to improve access to care and treatment options in order to advance the quality of life for people with bleeding disorders through advocacy, education, and outreach in collaboration with our founding member organizations, which are the other patient groups here in California. And we are happy to welcome you to the presentation today. I would like to introduce Amber. She is with the Treatment Center in Nevada. Looking forward to hearing her presentation today about women and bleeding disorders.
So how the medical world perceives you is dependent on health literacy. And as a provider, I will be honest, we completely suck at teaching our patients about health literacy. We use terminology that is overly complicated. We were trained with terminology that was overly complicated, and we continue to use it, although it creates issues. So health literacy is the ability with which people have the capacity to obtain and understand health information, and then can use that information to make appropriate health decisions. So there are times when we have comprehensive clinic and we perceive that we have told you everything that you need to make a good decision, when in fact, what we have said is actually not going to get you to where you need to be. But as medical professionals, we assume that we have done what we needed to do. This is impacted by culture, medical jargon, the context, and situational influences. And by context, when you're in for a visit, the whole context is determined by why you are there. When it's a comprehensive clinic, the context is a healthy visit. What is your weight? Are you having any bleeds? So the context is situational depending on what you're being seen for. It's impacted by culture immensely. How we communicate, how we talk is largely dependent upon the role models that we have in our culture or the lack of role models. How we feel and perceive the world around us is also dependent on our culture growing up, where we lived, where we were, where we come from. It carries forward. I grew up in a very rural area. I rode horseback and went hunting, and I didn't ever get into a taxi until I was 28 years old. So my view of the world at that time was very different than someone who has lived in the city. And so my thought process was very different than someone who would come from the city. This also affects how we seek care and how we respond to advice. So if we grew up in a tight-knit culture, we're more open to listening to everybody and absorbing that information, talking to people and coming to a decision community-wise. If we grew up without those social constructs, we're used to making a decision and hoping for the best because we didn't have the support in the background that we needed from what should have been our family or what should have been our role models. And so sometimes we carry that forward either consciously or subconsciously. So I wanted to review an example of how medical jargon has created issues for our population specifically. The word carrier. As many of you know, in my center, we no longer use this term at all because what it means is completely dependent on who it is that is asking. It is completely dependent on the provider. It is completely dependent on the situation. There's been no consistency into how we as the medical community are utilizing this, will continue to utilize it, and it just creates way too much confusion. Is a male affected with a bleeding disorder a symptomatic carrier too? Those are things that I've always asked people in terms of how do you view a mild hemophilia male? Do you call him a carrier too? And if he doesn't have symptoms, is he an asymptomatic carrier? That same thing applies regardless of gender. And this is a critical difference, is it just creates confusion along that line. And it creates confusion for the person who has a bleeding disorder. Am I affected? Will I have issues? There are a lot of women with lower levels of factor 8 and factor 9 who have joint bleeds, and they must be treated. They must get the same kinds of treatment that males with lower factor activities also receive. And we also know that if women have those traits within their DNA, they are at risk for some of the joint degeneration that we see even if their levels are recorded and they're recorded normal. In our state, we don't have a hemostasis lab that can do point of care testing. So we have to make clinical decisions. We have to decide, is this a bleed? What are we going to treat? And how are we going to look at it? And what we found is that when we test, it is a picture, a measurement of that moment in time. I wish we could have everyone go to sleep, draw their labs, and be able to say this is more accurate, but that doesn't happen. All of the testing that we do is tied to your fight or flight response. So if you get anxious, your levels falsely rise and give us an inaccurate measurement of how much activity may be in your blood. And that gives us an inaccurate estimate of how much is this patient at risk. And we also know from more knowledge in studying factor 8 and factor 9 deficiency that each person's threshold for the level at which they are protected is different and often dependent upon the other clotting factor activity levels that they have in their blood. For factor 9 deficient patients, how much factor 8 do they have? For factor 8 deficient patients, how much factor 9 do they have? So especially in my clinic where the community is sometimes transient, including our ER physicians who often change jobs every 3 years, we stopped using the word carrier on their medical alert. We started to use factor 8 deficiency or factor 9 deficiency so that when these healthcare professionals look at this, they know exactly objectively what it is that they are facing instead of carrier or hemophilia A or hemophilia B. They have to then remember, is hemophilia A 8? Is it 9? What are we dealing with? Maybe we should look at this and call that provider. For our women, we have found that when we have changed the medical alerts and put factor 8 deficiency, it is less likely to be cued in their brain to say, this woman has hemophilia and therefore I do not have to worry about her because I was trained to believe that women do not have hemophilia. So this is a huge example for us of how advocating gets to be a more objective assessment, to be more succinct in what we say and more specific. We say, you are a female, your activity level is this. Please call the HTC at this number for further instruction. That way, it doesn't place the patient in the middle of that conversation with the ER physician. The ER physician then knows, hey, call the HTC and they're going to guide me from this point forward. So there's many levels of different information and it changed at an exponential pace. We, at no point in history, have been inundated by information. Information changes hourly, minutely, and it can become frustrating. The studies that we tell you today may be completely reversed tomorrow, and that is frustrating. I think there's a sense that the medical community is impervious to mistakes, and that is completely inaccurate. We do the best that we can with the information that we have at the moment that we have it. How to access care is also affected by that because we have to be certain that when we access care, we don't bring the baggage with us. And by that, I mean treat every situation as if it's a teachable moment. Just assume that that physician or nurse practitioner or care provider that you're seeing has never had the opportunity to learn and you're starting from square one. And I know it's frustrating to start from square one every time you have an interaction with somebody, but oftentimes we make assumptions about what they should know or what they should do, and it creates more of a conflictual relationship than it does to ease both sides being able to hear each other out. And I have to say, in our own community, we have these biases. I treat a lot of older males who still have that purview that they struggle more than women because they have severe hemophilia. And so we have to address that as well. And we have our own biases as well in society. Everyone knows who Ryan White's mom is. Fewer people can tell me her name, and even fewer people can tell me what she likes to do as a hobby. She has become Ryan White's wrapped up into everything, but she is still a woman, well-respected, strong as hell, love her to death because she's been so strong. But She lost some of herself in this whole process, and that's what can happen to people. They can lose themselves in the labels that they become. So we have to work each day to re-educate ourselves, to take a look at things differently and go forward from there. So the problems with the lack of health literacy are well known. Higher use of emergency services. If the conversations we're having with patients are not effective and we don't know, the patients will then go to the emergency room versus calling us back. Or if we have instances where our offices are not well run, they won't be able to get that clarification. So I always advocate for our patients to say, if you don't understand something, please have the provider or clinician or person you're speaking to rephrase it and have them keep rephrasing it until you understand. The provider should be willing to understand that sometimes it takes a few times, even if it's the same language, to get the same information across. Increased episodes of hospitalizations are another issue. Lower ability to access preventative services. So if we don't educate people where to go and when and why, that can be an issue. Higher healthcare costs and lower quality of life. And so sometimes with the complexity of how our healthcare has become, people don't know how to navigate it. So I would advocate for every person, every year when your insurance comes or it changes, to actually read your summary of benefits from front to back. I know a lot of you are saying that is a terrible, terribly boring thing to do, but I assure you, you will learn things that once those situations arise, you won't have to worry, what did my insurance say that my MRI would cost? Because you will say, hey, I know where that is in my summary of benefits. I'm going to go back and refer to it, and I will know from there what you can do to then take that next step. And it creates a lot less issues than calling the insurance sometimes and trying to find that information out. And again, emotions. Anger is inherent in frustration, but it only breeds anger in others. And what I mean by this is, if every conversation is started with anger, there won't be anything that can come from that conversation. It's easy to assume that the person should know your whole story and know what you have been through and know every step of the way, and your anger can rise if they don't. And I have this happen to me too. This happens to everyone, every human, everywhere. They have moments of anger. When I have to explain for the 34th time to the insurance why factor is medically necessary, it is annoying. I sometimes do get short and you have to reset, take a moment and say, this person has never heard of hemophilia before. This is a teachable moment. What is it that I can say that they will understand? How can I make it connect to their life and create a picture and scenario that they would be more familiar with, because they're not going to be familiar with hemophilia. Shame is inherent, but it only leads to silence. This is critical for my women because oftentimes they feel that they are to blame because they have passed on the gene, that they have been responsible, but it is no more responsible than the gene that you've provided to dictate hair color, and it only leads to silence. So I'm really glad to see that women have come together and talked about issues and been able to advocate for themselves, because when this population was silent, the majority of them suffered in silence, and hopefully over time that doesn't happen in the future. Health literacy should be emotionless, like I said, but we're human, and every human, I don't care how much education they've had, I don't care what their job is, I don't care anything that they do, they're fraught with insecurity. They have those moments of doubt. They have to be confident in moments, but not everyone is going to be 100% all the time. And sometimes we just have to forgive that. The highest risk groups are older adults. Sometimes they're unable to keep pace with the technological advances that come with things. And so there comes a time when sometimes they quit trying. So it's also our role to advocate for our older women so that they realize that their suffering is important, that their arthritis wasn't just age-related degenerative changes. In some cases it is, but in some cases it isn't. And the more we can prepare them for things that they may encounter, the safer they will become. There are a lot of women out there with lower levels of factor VIII, and because they're older, they say, I don't need anything for my next surgery, and that's just untrue. We need to be able to protect them too. We need to advocate for our poorer adults who may not be able to access services such as everyone else would. So it's an ongoing advocacy at the legislative level, at the state level, to get safety nets in place to make sure that everyone is always taken care of at every moment in time. Limited education, we have to advocate for legislative processes that increase and improve education so that everyone can get to that threshold where they understand the language and the terminology that is used on an everyday basis. And this is true for minorities as well. They tend to insulate sometimes, and they don't always get the benefit of being with the entirety of the group. So we have to advocate that we always come together completely, that we don't separate people out based on any reason. And like I said, highest risk is women with bleeding disorders. Women with bleeding disorders are survivors, and they carry that like a badge of honor because, yes, they have absolutely survived. But I don't want these women to just survive. I want them to live and live a quality of life that they didn't think was possible. And I want that to become their badge, to kind of change that in time so that they can go on, and when they have kids, they can be able to say, hey, we know it was bad when I was older, and it's not acceptable to have heavy periods. And that's one of the things that comes up in my presentation on menstrual periods a lot is the products don't work for me because I bleed too much, and so I can't use that. And I said, no, the products will work if you are treated well enough. So there's a difference in mentality that we have to start getting to.
So thank you all again so much for your participation. Thank you again, Amber, and we hope that everyone stays well. And please, if there's anything we can do to assist you, don't hesitate to reach out to us at the council. So thanks for joining us today. Bye-bye.